Today we are going to start talking about aerosol drug therapy. So the first thing we're going to do is we're going to start our pharmacology review. Pharmacology is something that's going to come up again and again as you go through this program. It's a very important part of our job, not only respiratory medications, but as you get further along in the program, understanding about sedation drugs and cardiac drugs. So pharmacology is something you're not going to get away from. So let's start with a warm-up question. Would you give a corticosteroid to a patient during a severe asthma exacerbation? No. Why would you not want to give an inhaled corticosteroid to a patient in a severe asthma exacerbation? Because a corticosteroid is a long-acting controller. If we have a patient in a severe asthma exacerbation, we are going to give them a short-acting bronchodilator. Okay, so drug administration is how the drug is made available to the body to be used. So routes of administration include enteral and parenteral. So enteral means the drug passes through the intestines. So a pill would be enteral, or a medication that is delivered through a PEG tube. And a PEG tube is a tube that is surgically inserted into the intestines. So that drug is pushed through that PEG tube where the effects take place by being absorbed in the intestines. Parenteral is administration that the drug does not pass through the intestines. So an IV drug, an IM drug, nasal sprays, those are all examples of parenteral administration. So the administration that we are most concerned about is the inhalation route. So these are drugs that go directly into the respiratory tract. So liquids, so little ampules for nebulizer solutions, suspensions, dry powders. Those are all examples. It's important to know the most common devices used for inhaled aerosols. So MDIs, soft mist inhalers, small volume nebs, dry powder inhalers. So with drug administration, it's important to know the advantages and disadvantages of inhalation routes. So because of inhalation, these drugs are going right to the target organ, to the lungs. So the doses don't need to be as high because they don't have that first pass effect. The onset of the drug, because going to this target organ, is going to happen more quickly. So you're going to have those more instant effects. And you're going to have fewer and less systemic side effects because it's hitting those target organs. Some disadvantages may be the variables that are affecting the delivered dose. So when we talk about the variable of the doses, we mean a patient who may not be able to coordinate an MDI, or they breathe in too fast, so a lot of it hits the back of their throat, things of that matter. And hand in hand with that can come lack of knowledge of device performance. So maybe they think, you'll hear so many patients when they do their inhaler with their spacer and they hear a whistle. It's not supposed to whistle. And we'll go over more about this when we get to MDIs and devices used with them. So properly educating our patients on how to use their medication, when to use it, and the tools and devices that go with it is so important to educate them and for us to take the time to make sure that they truly understand. So when I talk about use among patients and caregiver, there are so many different devices that have the same goal in mind. So different kinds of spacers and nebulizers, even DPIs. They're all a little bit different. So if you're used to working in one facility that has specific types of devices, you may not know what either the patient gets from their primary doctor or they've gotten from another hospital, or something even as simple, something new that comes out in the field. So everyone's kind of like, what is going on? How do we use this? So it's very important not to just educate your patients, but make sure that you're staying educated, that you know the newest drugs that are coming out, that you know the newest devices that are coming out. So airway receptors, these are the receptors that these drugs are going to bind to create the effect that we are looking for. So know these airway receptors. This is very important. This is another thing that we're building the base for the program. Depending on where drugs bind is going to give the effects that we want. So if we know what receptors we want to stimulate or block, we can give and recommend the proper drugs. So we are looking in the airway at sympathetic and parasympathetic airway receptors. So remember, sympathetic is stimulated during fight or flight. So big deep breaths, increased heart rate, so it's going to cause bronchodilation. And then you have parasympathetic or cholinergic, which is rest and digest. So you're relaxing, you have a decreased heart rate, shallower breaths. So this is going to cause bronchoconstriction. So know the difference between the two. So neurotransmitters. Know your neurotransmitters. So you have sympathetic, so fight or flight. And this neurotransmitter is going to be epinephrine or norepinephrine. And if a drug is adrenergic, it's an agonist. So it's going to stimulate the sympathetic receptors. If you have an antiadrenergic or an antagonist, it's going to block these receptors. So an antiadrenergic is an antagonist and an adrenergic drug is an agonist. And then you have the parasympathetic receptors. And the neurotransmitter is acetylcholine. So cholinergic is an agonist, so it's going to stimulate these receptors. And an anticholinergic is an antagonist, so it's going to block these receptors. So it's very important to know these. And we get more in depth into receptors when we get to advanced pharmacology. So these are the major respiratory drugs, the major classes. So know all these different classes. We're going to go more in depth with a lot of these when we get to advanced pharm. So we are going to start with adrenergic bronchodilators. So remember, this is the sympathetic nervous system, and it's going to stimulate. And I apologize if I am a loud writer. So indications, always know your indications. So we have short acting, which is going to be for relief of acute and reversible airflow obstruction. If you have a patient who has a foreign body aspiration, it's not going to help. These are not going to help. These are for acute reversible airflow obstruction. Long acting is a maintenance. And these are for patients with obstructive lung disease. And when you are in your disease class with Derek, which you are starting pretty soon, how I say obstructive, how I remember obstructive diseases is C, babe, CF. So you have chronic bronchitis, asthma, bronchiectasis, emphysema, and cystic fibrosis are all obstructive diseases. Okay, so those are our obstructive diseases and for long acting. And then you have racemic epi, and racemic epi is an ultra short acting. And this can reduce airway swelling. What is a time that you think it would be important to reduce airway swelling? So this would be maybe your patient who has subglottic edema. This can be caused after you extubate a patient and they have inflammation and they may have stridor. So you would put on a cool mist aerosol to help vasoconstrict. But you could also give racemic epinephrine, which is also vasoconstricts. It also is used to control airway bleeding during a bronchoscopy. So because it's a vasoconstrictor, if you have a small little area of damage caused by maybe a biopsy through a bronch or some trauma from the bronchoscope itself, if you put racemic epi or epinephrine down the bronchoscope, then you can stop the bleeding with that. So the receptors in the airway from the sympathetic nervous system includes alpha receptors, alpha 1 and 2, which we're not going to go in depth with those until we get to advanced pharmacology. Stimulation of the alpha receptors cause vasoconstriction and a vasopressor effect. So a vasopressor effect would increase blood pressure. So alpha receptors, we deal more with those with cardiac drugs. Beta 1 receptor stimulation is going to cause an increase in heart rate and heart contractility. So we will also talk more about cardiac drugs in advanced pharm. So the ones that we are concerned for right now in our class is going to be beta 2 receptor stimulation. And this is what's going to give us those desired bronchodilation effects. Because remember, fight or flight, if we're running away from a bear and we need to take big, deep breaths, we want our airways as open as we can so that oxygen can get to the tissues. So beta 2 is going to relax the smooth muscle around the airways. And it's going to also increase mucociliary activity. And it does have some inhibitory action on inflammation release, mediator release. So from the last slide, what are 3 types of adrenergic bronchodilators? So we have the ultra short acting, which is like epi and racemic. We have short acting, and this includes our bread and butter drug, albuterol. We like to refer it to as albuterol because it seems that doctors try and order it for everything. And then we have long acting. And remember, these are our maintenance drugs, so salmeterol would be an example. So rescue, and then maintenance. So like knowing your indications, you should always know your adverse effects. So adverse effects with adrenergic bronchodilators. These are just some of the most common. So tremors, shakiness, the jitters. People may just describe it as feeling funny or they don't feel right. Headache, insomnia, because if you were stimulating all those receptors and you're stimulating the sympathetic nervous system, you have your heart rate's increased, your respiratory rate could be increased, especially for those that aren't beta 2 selective, like albuterol. So if you're stimulating beta 1, beta 2, alpha 1, and alpha 2, you're really stimulating that sympathetic nervous system. If you've ever had to have epinephrine due to anaphylactic shock, you feel wired. Nervousness. So some people may, especially if they have anxiety, before having this treatment, they could feel more nervous. It's just I've heard people say, feels like my heart's beating out of my chest. So something that you'll learn is patients may describe how they're feeling, and you have to kind of put 2 and 2 together when they say, oh, my heart's beating so fast. Then you know, okay, well, I just gave them albuterol. I should try and calm them down, remain calm with them. So something that's very important that we're going to start talking more about is our assessments of patients and when we are doing a treatment, what we need to be doing. So it's very important to always have a pre and post assessment. So this is what you're going to be putting into your patient's chart when you give a treatment. So pre, you want to give vitals. That includes heart rate, respiratory rate, oxygen, so your SpO2. And then you'll start your treatment. You're going to be watching your patient. And as we talk more about the treatments themselves, we'll go more in depth into this. And then during your post assessment, oh, I forgot breath sounds. How can I forget breath sounds? And then in your post, you're going to get vitals again. This way you can compare. Did this treatment help? Some breath sounds you might hear pre is wheezing, tightness, diminished. Post, even if it's improved a little bit, you can still hear wheezing, but it's not all throughout. Maybe it's just one lobe. You're comparing, am I doing treatments that are helping the patient? Do I need to order them more often? Then you can take it from here and say, okay, well, this is my third. Okay, I'm sorry. Marilyn just walked in. She just did albuterol, and so she's going a little crazy. So let me start that thought over again. So you can take your pre and your post and compare it and say, oh, well, this is my third time in here, my third round. And you know what? Each time they've had less and less wheezes, or maybe, well, since the beginning of shift, they've been clear. Or they just had a little bit of wheeze. I don't think I have to wake them up. I think they can just do treatments during the day. And most hospitals will have a protocol. It's called a respiratory protocol, so that you have the power to change those orders because it's under your scope of practice. And we'll get more into how to change orders and when it is appropriate. So it's very important to do pre and post assessments. You also need to chart and look for any adverse effects. Because remember, if your heart rate increases greater than or equal to 20%, you need to stop the treatment. So an adverse effect would be that increased heart rate. So you would chart it, and that may be another time that you're saying, okay, well, every time I give him albuterol, this just isn't working. His heart rate is going up. Maybe it's time to think about switching him over to Zopanex. So anticholinergic bronchodilators, I don't know why, but this program didn't insert this one slide. So this will be slide 10 on the PowerPoint. So anticholinergic, so remember it's an antagonist, so it blocks the muscarinic receptors. So M1, M2, and M3 are the ones that we are worried about. So it blocks those receptors. And remember, this is the parasympathetic nervous system. So indications. So always know your indications. So we are going to use these for maintenance of COPD. So COPD maintenance. Oops. It can be combined with beta 2s if they require additional bronchodilation to reverse that airway obstruction. So anticholinergic bronchodilators is the bromides. You have ipratropium, tiotropium, and umcilidinium bromides. And remember, they can be combined, so you have combo drugs. And that's with your anticholinergic and your adrenergic. And I apologize for my handwriting. So this is going to be ipratropium, and albuterol. So those are Combivents, is the MDI, Combivent. And Duoneb. Now, sometimes you will see doctors order Duonebs for everybody, whether it's an asthmatic or a COPDer. That's okay. It's not going to hurt the asthmatic patient. It's just trying to give that extra bronchodilation. Typically, you only use albuterol only for asthmatic patients. The anticholinergic helps COPDers more. So adverse effects for anticholinergic drugs. The most common, and this is going to come up again, so remember, the most common is dry mouth. You also have pupillary dilation, increased intraocular pressure, so your eyes. You can have an increased heart rate. It's not as likely, but it can happen. And then urinary retention. So this is something that you need to pay attention to is if you have a CHF patient, because they're more likely to be what we call fluid overload. And I'm not sure how much terminology you guys have, how your other teachers have taught you. So if I ever mention a term or a phrase and you don't know what it means, don't be afraid to ask. Because sometimes I forget where you're at in the program and what you have already covered and what you haven't. So that's just a side note. So for CHF, they're more likely to be fluid overload. So that's congestive heart failure. They have a hard time getting fluid out of the body. So that's something that we want to look at, because if they are not voiding and urinating and their body is holding on to this fluid, and especially if they have CHF and it has nowhere else to go, it can go into the third space and they can develop pulmonary edema. And also a sign of fluid overload would be a patient with pedal edema. So really, really swollen feet and ankles. So mucus controlling agents, our favorite. So acetylcysteine or mucomist, it's disgusting. It smells like rotten eggs. So if you're giving it to a patient, be careful not to spill it on yourself. Oh, one time our cardiac doctors used to love giving it. It was part of their protocol for new hearts. And I was my first patient on my first rounds, and I spilled a little bit on my scrub top, and I could smell it the rest of the 12-hour shift. It was awful. So be careful. So it's typically given to reduce the accumulation of airway mucus. There's no study saying mucomist works. But until they stop prescribing it and using it for airway clearance, we need to educate you on it. A side effect is it may cause bronchospasm. So if you see an order for mucomist, but you do not see that the physician ordered albuterol, you need to make sure that you say, hey doc, and put it nicely, I see that you have mucomist. And I think that it would be a good idea to order albuterol. So you should pre-treat with albuterol. Okay, and then Dornase alpha or pulmozyme is only indicated for the management of cystic fibrosis. It breaks down, and we'll go more in detail with this in Advanced Pharm. It breaks down the DNA polymers in their mucus to help thin it out so it's not so tenacious and sticky. Side effects is voice alterations, pharyngitis, a rash, chest pain. Personally, Marilyn has not had any of these, so that's wonderful. So pulmozyme is expensive. It needs to be refrigerated, and it needs to be protected from light. So, for example, Maryland's pulmozyme, what they bill insurance is like how much is it? It's like $3,500 a month for a 30-day supply of pulmozyme. So that's just something to keep in mind, that when you're pulling these drugs out of the Pyxis or the medication machine, whichever brand the hospital has, and you're pulling these drugs out of the fridge, the longer that they're in your pocket or they're in your computer on wheels or however you're carrying your meds, it's important to be mindful that these drugs can be expensive. And so if you wait too long or you pull it too soon and you're not able to give the drug, you're wasting the hospital's money and their reimbursement for that drug, which comes out of the respiratory department's budget. So just kind of be mindful, just food for thought. So moving on to inhaled corticosteroids. So indications is for inflammatory maintenance. So this is a maintenance therapy of persistent asthma or severe COPD. So maintenance, this is not a rescue drug. Corticosteroids can be combined with long-acting bronchodilators, which we will get to in a couple slides. So some notes. Remember, patients should always rinse their mouth out after they use this. They should rinse, swish around the water, and spit it out. I've seen patients who have swallowed it, which really grosses me out. But they should rinse their mouth out because that can cause thrush, which is a fungus. And that would, if you see a patient who their breath is going to smell funky, and then they could have it gets a thick white layer coating on the back of their throat and the back of their tongue. And then patients should understand that you have to use it consistently. In order for it to work, you have to be using it on a daily basis. And remember, these can be either Q day, so once a day, or BID. And patients who have persistent asthma or severe COPD and require these drugs should be using a peak flow meter regularly, especially your asthmatic patients, because we want to see where they're at. Are they in their green zone? Are they in their yellow zone? Are they in their red zone? How often are they having symptoms? So they should be keeping track of all of this. On another note, another thought is a tip for you guys. You don't have to do this. Something that I would do on my first rounds, because I worked nights, so it would be their second or last steroid treatment of the day. I would always make sure, if I knew I was going to a patient's room and I was giving them an inhaled MDI, a corticosteroid, bring a cup or two, because then you have that cup. You don't have to run back out of the room if they don't have one in there, so that they can rinse their mouth. If you are being proactive and saying, hey, you need to rinse their mouth, and then you don't have a cup, or they're like, I don't have a cup in here, I'll just do it in the morning, or I'll just wait a while, I'll have my nurse come in. If you already have a cup and you're like, no, let's just do it right now, I'm here, I'll help you, then you don't have to get out of bed. And just, it's the little extra things that will make your life easier and help your patients. So these are a list of some inhaled steroids. So one important one on this list to remember is budesonide or Pulmicort. And this isn't available as an MDI, but it's also available as a nebulizer, and it's the only one that you can nebulize. Another very common one would be Flovent, and then Asmanex. Okay, so these are combination drugs. So they're inhaled corticosteroids along with LABAs, so long-acting bronchodilating agents. So fluticasone and salmeterol, so Advair, is very common. It's also very expensive, so some hospitals do not use it. It's available as a discus, which we'll go over the DPIs later, and then HFA, so a MDI. So if you see HFA, it equals MDI. And then you have Symbicort and Dulera are also very popular. And oftentimes hospitals, if they don't carry Advair, will have one of those too, and they can switch them out. So if you have a patient who, say, takes Advair at home and the hospital doesn't have it, it is okay to substitute it with something that's going to do the same thing. So as long as you're substituting a same classification of drug, it should be okay, as long as they don't have allergies to the new drug. So COPD and asthma are two of the biggest disease processes that we treat with aerosolized medicines. So we will start with COPD. So this is going to be chapter 12 in your disease book. Okay, in order to diagnose COPD and figure out what stage of COPD they're in, you need to have PFTs. So require PFTs. So the gold standard, the gold guidelines set the standards for diagnosing and developing the treatment plan for chronic bronchitis and emphysema. So the gold guidelines define COPD as an airflow limitation that is not fully reversible. So it is not fully reversible. It has reversible properties, but there's enough damage that it is not a fully reversible airflow. And then the MMRC is the breathlessness scale. So they use that along with those gold standards to predict the mortality. So this is the classification. So you're going to look through these different groups, and this is in your book. So know the different groups and how they are classified. These groups are based on their risk levels and how many symptoms they have. So gold 1 and 2, if they have less symptoms, they're going to be in group A. If they have more symptoms, they're going to be in group B. And then gold standards groups, gold 3 and 4, if they have less symptoms, but they're still high risk, they're going to be in group C. If they're gold 3 and 4 and they're high risk and they have more symptoms, they're going to be in group D. So these are going to be later stage disease processes. Okay, for asthma, this is going to be chapter 13 in your disease book. So GINA, which is the Global Initiative for Asthma, is the clinical guideline program for prevention and treatment of asthma. I highly recommend visiting their website. They have a lot of great information. Along with COPD, it requires a PFT to diagnose because they want to make sure that it's a reversible airway obstruction. So they'll do a methylcholine challenge and see if they react to albuterol. So classifying asthma is similar to COPD, but it's going to be classified by the control of symptoms. So control equals symptoms and lung function. Are they having nocturnal symptoms? Have they missed school? Have they missed work? Do they sleep at night? Do they fall asleep during the day? And then their PFT is going to measure the lung function. So take a look at this and know this as well. Go over it because we are going to use these steps for pharmacology. So we're going to start with a rescue inhaler in step 1. And then as their steps increase based on their symptoms and their lung function, we are going to prescribe the necessary MDIs or nebulizers or treatments that they need, which can include inhaled corticosteroids. And then as you can see in step 3, that's when we add the LABA at a lower dose. So this is going to help us guide to what our patients are going to need. So for example, there might be a question that says, your patient is in step 3 asthma after PFTs. The physician has said they're in step 3. What would you recommend for that patient? Well, you would recommend a short-acting bronchodilator as needed. And then you'd also recommend an inhaled corticosteroid combined with a LABA. So this is where we will stop for today. Before I forget, if we see a patient in the hospital and it's their first exacerbation and they've never had symptoms like this, you should refer them to a primary care physician or a pulmonologist because they have to have that PFT. Remember, we cannot diagnose them. And sometimes you have to be very careful what you say to patients because they may hear one key word and take it out of context. So make sure that you're saying, hey, you had wheezing, you had this exacerbation. I think you should probably follow up with your primary care doctor. Here's, this nebulizer treatment seemed to help you. I think you should follow up with your primary care doctor and the physician as well. At the hospital will refer them to a primary care or straight to a pulmonologist. Okay, so we'll stop here for today. I hope you have a great weekend and please reach out to me with any questions.